Good morning, everyone. Good morning. Welcome to the Lee W. Bass Community Pediatric Grand Rounds lecture today. We are so excited to kick off this special lecture, which also kicks off our third annual HofKosh Pediatric Educator Symposium. We come together today to celebrate and elevate our scholarship in medical education, which is so important and critical to our mission here at Children's. I'd like to take a moment to thank all the educators that are here. I see some familiar faces back, as well as all the educators online. Your teaching and your dedication to our trainees is just really so appreciated. Your efforts shape our learners, and they also shape the care of pediatrics for generations to come, patients that you won't take care of yourself, but your trainees will take care of in the future, people that you'll never meet. Our Grand Rounds honors Dr. Bass and his many contributions to the practice of pediatrics. He had an unwavering commitment to teaching, especially as it applied to community teaching and teaching in that environment. We have many of our community educators here and online, and we are celebrating their work with us today. Dr. Bass was a strong believer in community pediatric training, and he was a mentor of many. He instilled the philosophy that the most satisfying and effective care comes from a combination of personal attention to patients and their families, as well as close involvement with the teaching programs at Children's Hospital. I believe Dr. Bass would be very pleased with our Bass visiting professor today, Dr. Patricia Poitevien. She is the Senior Associate Dean for Diversity, Equity, Inclusion at Brown and an Associate Professor in the Division of Pediatric Hospitalist Medicine at Hasbro Children's. She's a graduate from the Program of Liberal Medical Education at Brown University and residency training at Pediatrics in NYU. She spent nearly a decade in graduate medical education, serving as the pediatric program director at both NYU and Brown, and now a recovering program director, which I think many would resonate with here. And she's currently the immediate past president of the APPD Pediatric Program Directors. Her scholarship focuses on inclusion and mentorship of underrepresented learners in academic medicine and the impact of racism on medical education. She's lectured nationally on disparities in medical education and in healthcare and has led numerous workshops on building diverse and inclusive environments within academic medicine. And she'll talk with us about her work in this field today, both here at Grand Rounds and also as our visiting professor for our HofKosh Symposium, which will begin at noon today. In her role as Senior Associate Dean at Brown, she serves as the liaison to ensure that diversity and equity are high-level priorities and collaboratively works across the organizational system to implement effective policies and initiatives. And we're thrilled that she's here with us today to spend the day and teach us about this very important topic. So with no further ado, Dr. Poitevien.
Good morning, everyone. It's really such an honor to be here, to be able to really share in such a wonderful day celebrating medical educators with all of you here in Pittsburgh. I'm very touched that I can also be here to give the Grand Rounds that was named after Dr. Bass, part of the Dina HofKosh Symposium. I first met Dina when I was a very junior program director. I think I may have been a program director for a year or two through the Association of Pediatric Program Directors. And I was telling this story yesterday. When I first met Dina, she called me on the phone because she really wanted us within APPD to sort of tackle implicit bias and the hidden curriculum in medical education. And this was just over a decade ago when we were just beginning to have conversations about racism and bias and discrimination in the clinical learning environment. So in Dina fashion, she called me and said, Pat, I really think that you and this other program director who I was very close with, I think you guys should come, and for the next national meeting, I'd like for you to do a workshop on implicit bias in the hidden curriculum. And while I was on the phone, I was panicked. I thought, why on earth does this lady think that I know anything about this stuff? She probably assumes that I'm way smarter and know way more about this than I do, but clearly that is not the case. And I tried to convince Dina over the phone that I was not the person for this job. I was a brand new program director. I had no idea what I was doing. I was just trying to figure things out. And the last thing that I wanted to do was present nationally on this topic that was at the time really the kind of third rail for us. And Dina listened to all of my concerns and my worries. And in very typical Dina fashion, she said, Pat, you guys are going to be great. I'm really looking forward to hearing what you guys have to say. So over a decade ago, I was panicked to talk about something as simple as implicit bias. And over a decade later, I spent all of my time and most of my career really researching and lecturing about this. So clearly, Dina saw something that I did not see. So it's really an honor to be here speaking today. And so I only really have one disclosure, and that is that I'm a Black woman in academic medicine. And that means I'm a member of a very tiny sorority. Only 1.7% of physicians in academic medicine are Black or African American. And so the work that I'm going to present to you today, naturally, is deeply personal work. And my hope is that the data that I present will help to tell a story. And this story doesn't only belong to me, but it is reflective of many of my experiences and many of the experiences of underrepresented people in this space. And I'm telling this story with lots of facts and lots of references, but I'm telling this story in an effort really to raise awareness, but most importantly, to activate us and help everyone become an agent of change. So our goals and objectives today, well, my goals and objectives today will be to illustrate the impact of racism in medicine, to really describe how racism and whiteness impact the clinical learning environment, to reveal how diversity, equity, and inclusion at its best is already integral to what we do and our best practices in the clinical learning environment, and then to highlight some of those promising practices for making our clinical learning environment more inclusive. And so I'd like to start with a definition of race and racism to make sure that we're all on the same page. I'm going to presume that everyone in this room already knows that race is not a biological construct. Kamara Jones, a family medicine physician and epidemiologist and former president of the American Public Health Association, defined racism specifically as a system of structuring opportunity and assigning value based on a social interpretation of race. She went further to say that race was nothing more than a system to group people based on skin color and other apparent physical differences, but that the purpose of race was really the purpose of race was to give power, and is to give power, to some over others, and to justify social and economic oppression. Again, it has no genetic, scientific, or biologic basis. More importantly, we often use race as a crude and an inaccurate proxy for socioeconomic status, culture, and genetics, but in reality, it's a precise measurement of a social classification of people in a race-conscious society. In other words, race is not a biological category that naturally produces health disparities because of genetic difference. Race is a social category that has staggering biological consequences, but because of the impact of social inequality on people's health. Despite the fact that race is not a biological construct, we still see it appear as one in many areas of clinical care. Take, for example, clinical practice guidelines. Courtney Gilliam, who is the first author on this paper, was a PHM fellow at Seattle Children's when she performed a systematic review of pediatric clinical practice guidelines. And what she found was that in reviewing 400 of those guidelines, about 30% met criteria for her full review, excuse me, because of the use of race or ethnicity terms, and that the use of race occurred 175 times in either background, clinical recommendations, or future directions. The fact that this occurred had a potential negative effect nearly 50% of the time across 73 clinical practice guidelines. In 2020, the AAP, realizing just how embedded in our clinical practice guidelines racism was, actually put out a statement, and the annual leadership forum passed a resolution that prohibited the use of race-based medicine. And in that resolution, they state, the Academy shall end the practice of using race as a proxy for biology or genetics in all their education events and literature, and require that race be explicitly characterized as a social construct when describing risk factors for disease with all presentations at AAP-sponsored conferences. Now, the UTI calculator is probably one of the best known examples of this in the world of pediatrics. And I know that many of you here are really familiar with it because the UTI calculator was based on two major studies of urinary tract infection in children, one based right here in Pittsburgh and the other at CHOP. And the studies seem to indicate that in a population of children between the ages of 2 and 24 months who presented to the emergency room with a fever and were ultimately diagnosed with a UTI, a larger number of those patients happened to be girls, had a fever over 39 degrees Celsius, were below the age of 12 months, had no other source of infection, and importantly, were white. Based on this data, the UTI risk calculator 1.0 was conceived and included white race as a risk factor. Now, despite knowing that race is not biologic, the idea was so deeply embedded in how we think about differences in human beings that none of the very talented scientists who put the UTI calculator together bothered to say, this makes no sense. Why would a white girl have a greater risk of UTI compared to a Black girl? As Joe Wright wrote in the AAP policy statement issued in 2022, in this case, quote, in this case, race was inappropriately inserted as a default biological proxy in lieu of incompletely explained epidemiologic observation. Now, pediatricians and researchers right here at Pittsburgh took up the challenge. In rethinking the UTI calculator, they decided they really needed to re-examine old data and evaluate new data. And they did just that in the creation and the release of the UTI Calculator 3.0. They asked more questions, and importantly, they decided that race could only remain a part of the UTI calculator if two very important conditions were satisfied: that the association between race and UTIs was supported by available evidence, and that two, race could not be replaced with other variables without adversely affecting the accuracy of the calculator. What they found in the re-examination of the data was actually there were two factors that they could replace race with that did not change the results of the UTI calculator, and that was duration of fever and previous history of the urinary tract infection. Now, the only reason why this change could happen was because there was some recognition and acknowledgement, not only that race is not biologic, but that whenever we're utilizing race as a biologic proxy, as a proxy for biological differences, that we as scientists and investigators need to re-examine the data to better explain what those differences actually represent. And so if race is not biologic, as we have been led to believe, then what is it? And this goes back to Kamara Jones' definition. Historians and sociologists have long held that race as a sociological construct was invented to reinforce a social hierarchy of power and privilege. In order to do this well, the architects of racism also had to create a concept of whiteness. And this is something that we don't often talk about in medicine. Whiteness is actually a well-studied historical concept and was originally invoked by W.E.B. Du Bois in the 1930s. What Du Bois describes here in this quote is how whiteness and the privileges that whiteness provide are currency. This is important because it serves as a driver to actually maintain racism. We need to have a system of racism in order to protect and uphold the value of whiteness. If whiteness holds an inherent value and a group of people are assigned white as their race, and they get to benefit from that assignment, as long as that group is large enough or powerful enough, then any moral or ethical desire for justice and equity becomes muted. Even during the time of slavery, the privilege of whiteness was not equally applied to all white people. And the fact that it could transform so easily reminds us that the reason why we changed the definition of whiteness is in order to maintain power and privilege. So if you think back to the time of slavery, there were different levels of privilege for land-owning whites, for example, and for white men in comparison to white women. And when Irish and Italian immigrants began to arrive on our shores, they were not considered white until they were. Each time the integrity of racist systems was threatened, the definition of white changed in order to maintain the status quo. Whiteness historically has been wielded in very specific ways at different times to serve the interests of those who have most to gain from the concept of whiteness. And even though whiteness did benefit white people over non-white people, it benefited different types of white people differentially, which means in order to keep whiteness intact and functioning, and in order to maintain racism, we have to create an illusion of benefiting all white people, even when whiteness doesn't. This has also been called strategic racism, a term that was coined by Ian Haney Lopez. It refers to purposeful efforts to use racial animus as a leverage to gain material wealth, political power, or heighten social standing. Haney Lopez explains that strategic racism is not even fundamentally about race. The driving force behind strategic racism is not racial animus for its own sake or brutalizing individuals who are not white out of hate. It is the pursuit of power, money, and/or status. If another means is available of gaining these ends, individuals who are utilizing strategic racism will use those instead of or in addition to race. Just as dog whistle politicians today also often use gender, sexual orientation, and religion to really whip up hysteria along those other lines too. Strategic racists act out of avarice rather than animus. Their aim is to pursue their own self-interest, and racism is merely a route to an end and not the end itself. And although this concept feels new to us in medicine, it's not new in history and in politics. And Lyndon Johnson, in an interview with Bill Moyers, is known for saying, if you can convince the lowest white man he's better than the best colored man, he won't notice you're picking his pocket. Hell, give him somebody to look down on and he'll empty his pockets for you. In order to understand the power of racism and the insidious nature of strategic racism, we all in this room have to use a very different lens. Critical whiteness is one of those lenses that is used in sociology and history, and it really examines the social construction of whiteness and its implications for power, privilege, and identity. It focuses on how whiteness functions as an unmarked norm, shaping social, political, and economic structures in ways that benefit some white people, but not all. When utilizing a critical whiteness lens, what individuals and academicians do is really think about whiteness as a social construct, ask questions about how whiteness might confer power and privilege. They really try hard to de-center whiteness, meaning trying hard to think about how whiteness has become the default norm in our society and how we can really change that. They think through how white identities are formed. They critique how whiteness is normalized and leverage all of this knowledge to deconstruct racial inequities. Critical whiteness, in my strong opinion, is one of those lenses that we need to incorporate more into medicine and how we think about how racism impacts not only our patient care, but our clinical learning environment in order for us to really make significant and impactful change. Now, switching gears just a little bit, many of you have heard about the growing concerns about the pediatric workforce, in particular, following the pediatric match results this year. The reasons behind the decreasing pediatric workforce are multifactorial, but it is not coincidental that our challenges in diversifying the pediatric workforce precede our challenges with a sufficient workforce, period. And when we think about the pediatric workforce and our healthcare workforce in general, we really have to start from the beginning, because obviously, well before a medical student decides to become a pediatrician, at some point, they have to be allowed into medical school. And when you look at the data of who comes into our medical schools, you begin to understand why it's been so hard for us to diversify our pediatric workforce, and actually why it's so hard for us to keep a steady influx of students coming into pediatrics at all. So in this study here by Grabowski, they actually looked at the number of applicants and matriculants to medical school. And what they found is if you look at all nearly 2,000 four-year public or private universities that report race and ethnicity enrollment data in the United States, about 200 schools actually produce 80% of the applicants and matriculants to medical school. That is 11% of our universities nationwide. And if you look at the demographics of those universities, what you'll find is that when their students, only 7% are Black, only 14% are Hispanic, and about half are white. So if these are the individuals who are coming into medical school, that gives you an idea of what the diversity of our medical workforce is going to be. And of all students, importantly, entering medical school from 1988 to 2017, nearly 80% of matriculants came from the top 2 household income quintiles. So not only a very homogeneous group of individuals based on race, but based on lived experience and socioeconomic status. Not surprisingly, when AAMC reports its data, which it does every year, about medical school applicants, what we find is that this mirrors the data that I just shared. About 50% of medical school applicants are white, about 1/3 self-identify as Asian, only 10% self-identify either as Black or African American or Hispanic or Latin A, and a very small percent, 0.2%, which isn't represented here in this graph, represent Alaskan Natives or American Indians and Native Hawaiian Pacific Islanders. And so you start with a very, very small pool, and you make it even smaller when you start to look at the medical school acceptance rate. The pool of students from historically underrepresented groups is already lower than white students, and the disparity only worsens as we move through the process of getting into medical school. The overall average acceptance rate to medical school is 41%. But the variability in rates aligns precisely with differences in racial and ethnic self-identification. In 2022, white applicants enjoyed a 44% acceptance rate at one end, and Black or African American applicants had a 39% acceptance rate at the other end. Not surprisingly, this then shows up in pediatric trainee representation. When comparing the demographics of pediatric trainees to individuals in the United States, all you have to do is compare the blue bars to the red. For every minoritized group, we fall extraordinarily short of having similar representation in our trainee workforce. This data is from 2019, and the AAP first issued a statement on workforce diversity in 2000. So over 20 years of our concentrated efforts, we have still not been able to close this gap. And when you look back to 2007, the green line representing the percentage of underrepresented groups in the US population, and the blue and red lines representing the percentage of underrepresented in medicine pediatric residents and fellows, respectively, you'll find that we are exactly where we've been. There's really been no progress. And many underrepresented residents who actually make it into our clinical learning environments report terrible experiences. They report microaggressions, being tasked with diversity work, and challenges in negotiating their professional identity. Disturbingly, unpublished data that was collected by the ACGME revealed that in 2015, Black and African American residents accounted for nearly 20% of all residents who were dismissed, despite comprising only 5% of all resident populations. Recent unpublished ACGME data that was presented at the Organization of Program Directors Association meeting in April of 2023 further revealed that from 2011 to 2021, Black and African American residents were 1.58 times more likely to prematurely leave a training program compared to their white counterpart residents. And American Indian and Alaskan Native residents were 1.4 times more likely to do so. Additionally, during this same period, Black and African American residents were 1.59 times more likely to withdraw from a program compared to white residents. Of course, this plays out, not surprisingly, in the number of underrepresented faculty across all specialties. When you look at data that compares the number of faculty who are underrepresented across departments from 1979 to 2018, what you'll see is that in 40 years, we've made minimal progress. The greatest rise between 79 and 2018 was among Hispanic faculty, whose numbers grew from about 2.5% of all faculty to about 5.5%. The numbers increased for Black and Native American faculty as well, from about 0.1 to 3.6% from 1979 to 2018. The highest proportions of URM faculty in 2018 were found in primarily 4 departments: OBGYN, public health, preventative medicine, 5 departments: preventative medicine, family medicine, and pediatrics. Yet, even in these departments, like pediatrics, the distinction was really minimal over the 4 years, and faculty still were still represented less than 16% of the time. So you'll see here in pediatrics, between 1979 and 2018, we went from 5% underrepresented faculty to about 11% underrepresented faculty. And that small number of historically underrepresented faculty continued to dwindle due to attrition, as Dr. Blackstock outlines in this piece that she penned in January of 2020 for a stat. She writes, "I never thought I would leave. My presence and work was significant to my patients, students, and colleagues, but I could no longer stand the lack of mentorship, promotion denial, and work environments embedded in racism and sexism." Racism affects academic medicine in multiple interdependent ways. It bars entry into the field for learners who have been historically underrepresented in medicine. It encourages bias in assessment. It interrupts professional identity formation, prevents sense of belonging, and creates a hostile learning environment. For faculty who are underrepresented in medicine, racism manifests as persistent marginalization, a lack of leadership opportunities, disparities in promotion and tenure, exploitation in the name of service, and burnout. These drivers contribute to a workforce which is not representative of its patients and to a clinical environment which cannot further the provision of equitable care. And just like we have decided as a community to examine racial differences in pediatric health outcomes with both cynicism and curiosity, and just as the AAP has asked us to be aware of how we use race as a social proxy, often for racism and whiteness themselves, we must apply a similar scrutiny to the clinical learning environment. Our ongoing challenge in recruiting, training, and retaining a diverse workforce is often symbolized as a leaky pipeline. But this analogy is completely inappropriate. If you have a leaky pipe in your house, you don't often think, maybe if I change the composition of the water and make the drops better, the pipe will stop leaking. On the contrary, you immediately assume that the problem is with the pipe and try to determine which environmental factors have led to the corrosion of the pipe and think to yourself, how am I going to replace this pipe? Well, in academic medicine, our approach to the leaky pipeline has been to try to make the water better. We offer the drops of water, our learners and our junior faculty from historically underrepresented groups, supplemental instruction, wraparound mentorship, tools to build community, as if they are the problem, without ever investigating what is rotting and rusting the pipe in the first place. If we think of the clinical learning environment as one integrated unit, where patients are cared for and learners are educated, where faculty and staff work together to support those two objectives, then it would follow, if racism impacts our clinical practice guidelines, how we assess, diagnose, and treat patients, doesn't it then follow that racism likely impacts how we recruit, assess, and train learners? And furthermore, how we recruit, mentor, and promote faculty? It is no secret that racism is a powerful driver of health inequity and is probably one of the most, if not the most, influential social determinant of health. Its power comes in large part from its deep historical roots, which permit it to be broadly influential and profoundly insidious. We could spend the next several hours, perhaps even the next several days, really speaking about how racism impacts health outcomes. But instead, I'm going to rely on a simple yet precise summary of the impact of racism on health outcomes that was published in the New England Journal of Medicine by Zinzi Bailey and others in 2021. In the article, she and her co-authors distilled down how structural racism in the United States has affected health outcomes of Americans in three important ways: through residential discrimination, the criminal justice system, and police violence, and lastly, directly through unequal medical care. We'll start with redlining and residential segregation. So home ownership, one of the most common ways to transfer wealth in the US, has a racist past. Redlining was the practice utilized by the Homeowners Loan Corporation, a federal agency founded in the 1930s, to expand home ownership following the Great Depression, to determine which neighborhoods were worthy of receiving mortgage dollars. Neighborhoods considered high risk or hazardous were often redlined by lending institutions, denying them access to capital investment. The HOLC would actually draw red circles around predominantly Black neighborhoods, limiting access to home ownership for Black families who sought to live in those neighborhoods, and limiting availability of intergenerational wealth transfer. This was all completely legal and sanctioned by the American government. Redlining officially ended with the Fair Housing Act, but the die had already been cast. In neighborhoods that are redlined, we see enormous wealth, education, and health disparities in our children. In the United States, 32% of Black children and 31% of Native American children, as well as 26% of Latinx children, are living in poverty, versus just 11% of white children. Disparities in access to education, as well as racism experienced by students in their educational environments, greatly impact the educational trajectory for children. We see disparities in high school graduation rates and chronic absenteeism from school, which disproportionately affect children of color and children living in poverty. According to the United States Department of Education, students from historically marginalized groups have less access to experienced teachers, advanced coursework and resources. They are less likely to be identified for and receive special education services. They are more likely to receive harsh punishments for behavioral transgressions. African American and American Indian children are overrepresented among children experiencing suspension. In fact, the US Department of Education reports that African American children in grades K through 12 are suspended 3 times more and expelled twice as often as white students. In certain states, school districts with more non-white children receive less funding at any given poverty level than districts with predominantly white children. As pediatricians, we of course understand how educational disparities impact health disparities, but there are health disparities that are linked directly with redlining as well. We have seen increased rates of preterm birth, maternal depression, asthma, and mental health concerns in neighborhoods that were once redlined. Black premature infants, already at high risk due to their prematurity, also have higher rates of morbidity secondary to bronchopulmonary dysplasia, intraventricular hemorrhage, when compared, and necrotizing enterocolitis when compared to white premature infants. This is in addition to the impact that poverty and poor education, both factors significantly influenced by home ownership, have globally on health inequity. Next, we'll look at the impact of mass incarceration and police violence. Policing policy in the United States is deeply embedded in historically racist roots. Police patrols were originally created largely to discourage slave rebellions and capture runaway slaves. After the abolition of slavery, Jim Crow laws were intended to push back any progress made during Reconstruction and reassert the dominance of white people over the formerly enslaved and their descendants. The role of policing in the criminal justice system was very specifically targeted to this end. Prisons and prison labor supplanted what was once slave labor through convict leasing, and the police often encouraged and participated in the terrorism of lynching. Following the Civil Rights Act, presidential declarations of the war on crime and the war on drugs by Johnson and Nixon respectively led to a 7-fold increase in the American prison population, with Black Americans being imprisoned at 5 times the rate of white Americans. The impact of mass incarceration, like housing, is both broad and deep. The formerly incarcerated face barriers to employment, public housing, federal cash assistance, student loans, and food stamps, as well as voting. Children whose parents or caregivers are imprisoned suffer consequences from loss of income as well as loss of stability. They are at increased risk of depression, anxiety, PTSD, asthma, and migraines. When male adolescents are exposed to racial profiling, even in the absence of an arrest, the hostile interactions lead them to report more symptoms of trauma and anxiety. Children who witness violence suffer more from PTSD, substance abuse, depression, poor school performance, suspensions, and expulsions. They are also more likely to have poor self-rated health. So it's clear that redlining and residential segregation, as well as mass incarceration and police violence, impact the health outcomes of our patients. But there is stuff happening within our clinical environments that impacts the health of our patients as well. The US mortality rate for Black infants remains over 2 times that of white infants. Native Hawaiian, Pacific Islander, and American Indian infants also suffer from mortality rates far higher than the national average. But when we stop to look at the care that Black infants receive during their NICU stay, for example, what we see is that even the care that we provide is impacted by personally mediated racism. Data demonstrates that Black preemie infants are less likely to be offered donor breast milk and follow-up referrals. Black and Latinx mothers reported more experiences of bias in the NICU than white and Asian mothers. And importantly, perceived racism, just the thought that someone was actually being racist against you, was significantly associated with preterm birth among women with mild to moderate depressive symptoms. Additionally, infants born to Black mothers were more likely than those born to white mothers to have drug screening performed on them, whether or not they met screening criteria when controlled for income, insurance status, and maternal education. We see disparities in things like insulin pump use in African American and Latinx children, likely connected to caregiver perceptions of cost, but also provider perceptions of family confidence. The result is that Latinx and African American children have a higher mean hemoglobin A1C level, and that more Black children suffer DKA and severe hypoglycemic events compared to white or Latinx children. Black children experience a 2-fold greater risk of death due to type 1 diabetes mellitus compared to white children, even though the incidence and prevalence of type 1 diabetes is greater among white children. When mental health conditions are diagnosed, Latinx and Black children are less likely to receive treatment than white children and less likely to receive effective evidence-based mental health care. Non-white children were 2 times less likely to receive appropriate pharmacotherapy, and Latinx children with limited English proficiency are more likely to be hospitalized for acute management of mental health disorders. Black children and adolescents are more likely to be diagnosed with psychosis or behavioral disorders, and Latinx youth were more likely to be diagnosed with disruptive behavioral disorders. This when compared to white children and adolescents who are more often diagnosed with mood disorders like anxiety and depression. Black and Latinx children with abdominal pain were less likely to undergo imaging. Black and low-income children also had increased odds of perforated appendicitis, intensive care admissions, and longer lengths of stay. In children with confirmed appendicitis, Black children were less likely to receive any pain medications for moderate pain and less likely to receive opioids for severe pain. So as I said, I could go on for weeks because the data is pretty significant that racism clearly plays a role in how we care for patients, in addition to the health outcomes that they suffer. And as I said earlier, if our clinical environments are impacted by racism, it would be silly for us to think that our clinical learning and academic medicine environments are not, because they're all the same. And if we actually go back in history, what we find is that academic medicine and medical education also has racist beginnings. So Abraham Flexner, pictured here, is considered to be the father of modern medical education. In 1910, he published the seminal report on the state of medical education in the United States for the Carnegie Foundation. In the report, Flexner detailed his findings from in-person visits to 155 medical schools across 2 countries, the United States and Canada, and recommended sweeping changes to medical education. Flexner made clear in his report that the greatest challenge facing medical education was the proliferation of poor quality, for-profit medical schools. His solution was nothing more than a reduction in those medical schools. And in fact, in the introduction to the report written by Henry Pritchett, Pritchett outlined 5 key points, 3 of which are related directly to the number of schools and the number of graduates, using the large quantity of graduates as a proxy for the low quality of graduates. In fact, Pritchett states, the existence of many of these unnecessary and inadequate medical schools has been defended by the argument that a poor medical school is justified to the interest of the poor boy. It is clear that the poor boy has no right to go into any profession for which he is not willing to obtain adequate preparation. Flexner himself states, it appears then that the country needs fewer and better doctors, and that the way to get them better is to produce fewer. He then went on to recommend the closure of 124 of 155 schools. These recommendations disproportionately impacted historically Black medical colleges, the only place where Black physicians could be trained at a time where education was still segregated in this country. This resulted, of course, in the closure of 7 of 9 historically Black medical colleges and the creation of admission standards to medical school, which made medical education nearly completely inaccessible to most African Americans. In his report, he also managed to marginalize the role of African Americans in greater American society. And if we look at the numbers, the report did exactly what it was intended to do. In 2010, the proportion of African American physicians to African Americans in the US was actually less than that proportion a century ago in 1910. Flexner's actions not only led to a decrease in the number of African American physicians for over a century, but fundamentally changed how the quality of medical education was measured. Flexner's recommendations indicated that medical schools, quote, should be integrated into a university with a sufficient endowment and have a university department in one of the fundamental medical sciences. Flexner understood the financial burden created by this recommendation and even estimated in his report that at the time, a university department would cost $10,000 to $15,000 per year, and that a 200-bed hospital would cost upwards of $150,000 per year. Flexner's core argument was that having fewer medical schools would improve quality, which fostered a narrative of exclusion and scarcity, linking the value of medical education simply to its inaccessibility. He also connected a monetary value to the quality of the education, reinforcing concepts like elitism and classism within higher education. Flexner went on to consider what he called the special case of the Negro doctor and defined their role as protecting white people from the, quote, potential source of infection and contagion contained by African Americans. This characterization relegated the African American physician to a role of caring specifically for his own and created a second tier within which the African American could be a physician, but not at the same quality or caliber as a white physician. In examining the current state of medical education, we see that Flexner's transformational report continues to influence our understanding and behaviors as they relate to the assessment of institutions and of learners. Take, for example, the rating of medical schools by US News and World Report, a practice only recently questioned by those in academic medicine. The critiques of the US News and World Report astutely pointed out that the rating system underscores, quote, an elitist emphasis on the reputation and wealth of schools, and that, quote, the US News and World Report rankings are based on data not directly related to educational process, quality, and outcomes. The US News and World Report rankings do little more than reaffirm prestige and financial prosperity of schools, promoting a cycle by which the wealthiest schools seek those students with the most privilege and wealth, and vice versa, exacerbating disparities and creating competition that does nothing to advance the health of the public or the education of future physicians. And it is no coincidence that historically Black colleges and universities never even made the US News and World Report list, even the 2, Meharry and Howard, that Flexner left standing. Now, we continue to struggle to connect education to the quality of care provided, because for so long, we have let this proxy of wealth and prosperity, as well as inaccessibility and scarcity, serve as a proxy for quality. And so when you look at medical education now, residents' medical school of origin is only weakly associated with any measures of clinical competency. And although attempts have been made to rank residency programs based on perception by experts, which is the only rating that's available now, those ratings are completely unreliable and have zero correlation with patient outcomes. But we perpetuate exclusion, potentially threatening our own supply of physicians. What systems are we willing to uphold when we continue to engage in patterns of gatekeeping without any appreciable benefit to learners or patients? Now, remember when I shared earlier that only 11% of our universities produce about 80% of medical school matriculants? Well, there's also a negative association between medical school attendance and any community college attendance. So any individuals who use community college as a way to really engage with an institution of higher learning and to potentially become a medical student, that actually counts against them when they're applying to medical school. And when you look at first-generation college graduates, they are also less likely to apply and be accepted to medical school despite taking concrete steps to pursue a medical degree. Despite this, our efforts to try and diversify our workforce and make sure that medical education and really institutes of higher education are broadly accessible to individuals who are not only minoritized because of race and ethnicity, but might be minoritized because of socioeconomic status, because of class, because of income, all of those efforts are currently under attack. And it's so odd to me because the battle against DEI, which claims to fight against exclusion based on identity and identity politics, is actually just fighting to maintain the status quo. A current state, as I've just laid out, where racism and whiteness are so deeply embedded that they feel normalized. But in actuality, they are driving health inequities and workforce challenges that are problematic not only for Black and Brown patients, but for all of our patients. When we think about DEI and many of the myths that have been presented as examples for why DEI should be dismantled, you realize that they are really nothing more than myths. And these are myths that I pulled directly from Stanley Goldfarb's testimony to Congress that was just given a couple of months ago. And Stanley Goldfarb is the brain behind Do No Harm, which is a 501c3 that is funded specifically to dismantle DEI offices and DEI efforts in medical schools across the nation. So in his testimony, he makes these claims that critical race theory, which I'm pretty sure Stanley Goldfarb doesn't know what the definition is, creates a binary of oppressed and oppressor. He also claims that so-called, and he calls it so-called, gender-affirming care can inflict dangerous and irreversible harm on children. He claims that the ideology of anti-racism is creating new barriers to care, and that health disparities are due to actual differences in people of different races. So again, reversing decades of research that tell us just the opposite. And he thinks that people like me who talk about racism in medicine, that we're drawing attention to the problem, but that rather than drawing attention to the problem, we're actually helping to create the problem. But when we think about these attacks on DEI, where does this all come from? It really comes from fear. And there's a huge fear in changing the status quo, but that fear can actually be characterized even further. And I pulled this information from a fantastic article that was published in the Harvard Business Review. And they talk about the 3 threats that continue to fuel attacks against DEI. The first threat is status threat. And status threat is this idea that everything within our environment is like a pie. And if someone else gets more of it, then I get less of it. And what that really looks like is, well, I've always been at the top, which gives me access to the best. So if you're at the top too, if I allow you entry, then I will have less of that best. The other threat that usually fuels DEI is something that we might call merit threat. And this is the idea that the current system is based on a meritocracy, even though we can pretty much demonstrate that meritocracy had nothing to do with it. But there's such a deep belief in merit and that the idea that I've earned my position here, then if you can just have it based on your race, then what about all of my hard work? If you're just here as a DEI hire, what does that mean for how I actually attain the position that I have in this system? And then lastly, there's moral threat. And this one I think impacts many individuals on our environment. And moral threat is the idea that if the system is immoral and I'm a part of the system, then that must mean I'm immoral too. So I can't possibly say that the system is broken or dysfunctional. And that looks like, well, I'm a good person. If I have my position because of unearned privilege, then I must be a bad person. What you'll see here is that all of these fears have very little to do with individuals who are underrepresented. They all have to do with how individuals who are majority or who have power in a system, how they see themselves. They either see themselves as immoral or as not having merit or of losing their own status. And so when we think about DEI and all the threats to DEI, it's really important to make sure that the argument we're having is about how individuals who feel threatened about DEI, how they see themselves in the system, and not individuals who we think are being impacted by diversity, equity, and inclusion. So what I like to think about is, what would it look like if we just took DEI back? What if we decided what the definition of DEI was meant to be? Those individuals who understand that equity is so critically important to our clinical learning environment. Attacks on DEI are just the next evolution of maintaining whiteness, otherwise known as white supremacy. And attacks on DEI are nothing more than attacks on what I like to call identity, distinctness, and collectivism, because all of these resist the power of whiteness as a means to advance oppression. For example, if you value your own identity, whatever it is, you resist someone else defining your identity and the value of your identity as less than. That in and of itself is an antidote to oppression. If you value your own identity over the identity of whiteness, racism cannot exist. You cannot have oppression without some form of self-hatred. If you value the identity of others, for example, and celebrate how they are different than you, you resist the framework of oppression, which necessitates that you value yourself above others. And if you value the idea of a collective, you resist the requirement of oppression that we are all suspicious of each other and need to dehumanize one another, rather than see ourselves as a community of human beings, all responsible for ourselves and for one another. So let's imagine a clinical learning environment where collectivism, distinctness, and identity are the foundation of what we do. A clinical learning environment where DEI is literally everywhere. When we think about holistic review, for example, holistic review is nothing more than a flexible, individualized way of assessing an applicant's capabilities. We've already talked about how our systems of assessment right now actually don't even link our students and our learners to patient quality. But what if we actually used a balanced consideration and gave equal depth or value to experience, attributes, competencies, and academic or scholarly metrics, otherwise known as EACM. And when we consider those in combination, we might actually see the individual for who they are and what they could contribute to the value of an institution or a program's mission and goals. That doesn't sound particularly revolutionary, but within our environment, it actually is. And that's because we've always had this tension that we've had challenges calling out between standardization and diversity. For all the love that academic medicine gives to this idea of diversity, at the end of the day, there's really a tension there. We say that we have respect for the individual. We say that we value unique life experiences. And we say that we're looking for those student idiosyncrasies that make them who they are. But in reality, once they come into our space, the first thing that we do is say we have specific standards and core competencies. They're designed to limit any variability, and there's really only one single definition of the competent physician, and you have to meet it. Well, then we can't really have diversity in our space, can we? And we certainly cannot have inclusion, which is key to the clinical learning environment. So what does that look like? What does it look like if we can actually have DEI within the clinical learning environment and continue to produce high quality, in fact, increase the quality of care and the quality of trainees that we produce? If we have inclusion in our clinical learning environment, what that means is belonging will be one of the goals of the environment. Not to tell you how you're not fit to be a doctor, but rather to look at your individual and unique characteristics and say, this is why you're going to be a good doctor. And in that situation, professional identity formation, which is critical to the production of medical students and residents and physicians, can continue. And again, this already exists in some of the frameworks that we're using. Inclusion in CLE is a huge part of the competency-based medical education framework. That framework is learner-centered and patient-focused. It is a framework for training and assessment which is outcomes-driven. And it starts with a clearly defined competency based on learner outcomes and then designs training and assessment backwards based on those outcomes. The core components of CBME include explicit core competencies, sequenced progressively, and tailored learning experiences, as well as teaching practices which facilitate the developmental acquisition of those competencies. CBME meets learners where they are. CBME focuses on standardized care, not standardized caregivers. We don't all have to be the same. We all have to utilize our own unique talents to make sure that we're reaching a standard that is patient-focused and that we know actually makes patient care better. Now, what would equity look like in the clinical learning environment? Well, that would look like assessment that was free from bias, that would actually examine patient-centered learning outcomes and competencies as a measure of our learners in that space. And unlike the assessment framework of Flexner, where scarcity, limited access, and financial prosperity serve as proxies of excellence, CBME actually strives to define excellence through competencies required to attain desired patient outcomes. Rather than set up elusive assessment systems and standards for learners which favor those with access to generational resources and exclude first-generation and moderate to low-income earners, CBME requires formative assessment and individualized teaching that considers the unique strengths of each learner. Now, I use these examples because these are examples that currently exist in our clinical learning environment. Many people think of DEI as this sort of external functioning thing that has to be accomplished, and how can we possibly incorporate that into the care that we provide and the education that we provide? What we don't realize is DEI is already embedded in the standards of practice that we know are best. When you think about patient and family-centered care, for example, that cannot exist in the absence of DEI. There has to be an equitable approach to centering the family in the care that we provide. It requires deconstructing hierarchies and making sure that the voice of the family member and the patient is a critical part of the plan that you create. You cannot do that in the absence of DEI, but those same principles can be applied to how we teach our learners as well, and should be, because our learners and our patients are all functioning within the same environment. So if we're creating an equitable environment where we care for patients, that environment will also demonstrate itself in how we teach our learners. And frankly, DEI is nothing more than the thing that we show up to do every day anyway. It's already embedded in the modern perspectives of medical education. When you think about holistic review, CBME, and as I shared earlier, patient and family-centered care, they all rely on diversity, equity, and inclusion in order to move away from faulty and biased systems that actually perpetuate health disparities and educational disparities. When we think about diversity, diversity is nothing more than understanding the humanity of every individual who's in our environment. Equity relies on nothing more than trust that we should be establishing with our patients, and certainly that we have to establish with our learners. And inclusion is nothing more than seeing the value of each of those individuals in our clinical learning environment.